Deepak, are you able to hear us? Deepak, we are not able to hear your voice.
Hey, Dr. Deepak, am I audible? Yeah, Dr. Deepak, you may unmute yourself and speak. Can you hear us?
Yeah, I can hear you. Can you hear me now?
Yeah, now you can share your presentation, Dr. Deepak.
Yeah. Can you see my screen?
Yes, we can see.
Yeah. So should we start?
Yes, welcome to all faculty members and trainees for joining in this webinar session. I would request Dr. Kaustav to please start the session, sir. Thank you and over to you, sir.
Yeah, so dear trainees and students, DNB and all others who have joined in our series of head and neck oncology, this is one of the most important lecture and interaction, because head and neck reconstruction is an essential part to learn for all DNB students, surgical oncology, and this is not being taught properly. So this is important, and we have none other than Dr. Deepak Bala, who is a leading head and neck and microvascular reconstructive surgeon in India. He is an international faculty for many conferences and workshops. His work has been acclaimed throughout the globe, and he is today has consented, to be our faculty. Thank you, Deepak. Can we start the presentation?
Yes, sir. Thank you for the kind introduction. So today's topic is going to be about what's happening in head and neck reconstruction, what are the current trends in head and neck reconstruction, and why is it important for all oncologists to know reconstruction. So let's look at regional and local flaps initially. Then let us transition on to why we should think of free flaps in most of the circumstances and the role of free flaps in head and neck, and some special circumstances in head and neck. So you should remember that if you remove a tumor, you should be able to reconstruct the defect. If you're unable to do a suitable reconstruction, that patient generally does not undergo ablative surgery, because you can't just leave a hole and come out. So it is essential for form and function. Now we have moved away from just closing a hole to functional restoration. Now, there is no surgery without morbidity. So before selecting the flap, we have to look at the morbidity of the flap. And there's always an eternal debate between free versus spherical flaps. So what are the things that you consider when looking at the defect? Everything previously done was looking at the flap in 2 dimensions, that is the length and breadth. But now we have come to understand that there is a third dimension involved in the reconstruction of a defect. For example, if you do a bite resection, there's a lot of dead space in the infratemporal fossa. For example, if you do a central arch reconstruction of the mandible, you know that the floor of mouth and ventral tongue also need to be reconstructed. Now, the second aspect is whether we are going to do cutaneous reconstruction versus mucosal reconstruction versus full thickness reconstruction. So we have to see whether we can recruit local tissue, or we have to recruit tissue that is distant from the site of the defect. And then we have to look whether the defect is intraoral versus extraoral defects. And whatever the flap that we decide, we have to avoid tension or torsion during closure. Now, the site of the defect is very important. Extraoral defects or cutaneous defects can be reconstructed by skin, obviously. Intraoral mucosal defects, while it's ideal to use mucosa to close those defects, seldom do we get tissue that is of that quantity to close an intraoral mucosal defect. In those cases, again, we should use keratinized epithelium because that tends to shrink less than using muscle as the reconstructive modality, because muscle will heal by secondary intention, whereas skin heals by primary intention. So, what are the local and regional free flaps that we have? There's muscle flaps, there's adiposural flaps, there's skin flaps, and there are mucosal flaps. Now, what are the advantages of using a non-free flap, not using a free flap? So, they are robust, there's no microvascular anastomosis, they have withstood the test of time, there's relative ease of use, minimum donor site morbidity. It's good for debilitated patients and those who can tolerate only short anesthesia. It's extremely important in salvage, and it's extremely important in vessel depleted necks. Now, there are some problems with using a pedicle flap. The reach and arc of rotation is one of the most important things. It is not very correct to overstretch the limitations or the limits of a pedicle flap. It's also difficult to contour the flap, especially thickness. For example, if you raise a pectoralis major, there's no way you can reduce the thickness of the flap unless you plan the skin paddle slightly offset from the muscle, or you take a parasternal or inframammary paddle. So it's quite difficult to contour a pedicle flap. And there are only 3 or 4 flaps that are being used commonly, and there's very few pedicled bone flaps that are available. Of course, you have the pectoralis major with rib, you have the pectoralis major with sternum, but they are not as reliable as the free flaps that we are using. And the other problem is you have to understand the concept of angiosomes. The first and second angiosome will be reliably perfused by the perforator of the pedicle flap that goes into the flap. But the distal vascularity is suspect in some flaps like the deltopectoral flap. So you might have to raise the flap, delay the flap so that the choke vessels open up, and then go ahead and insert the flap after that. So that may take an interim period of 2 to 3 weeks. So the patient has to be made aware of that. And if you have Irilic or if you have ICG, you can always check for the distal vascularity, but that's not very commonly used. So what are the good scenarios for local and pedicle flaps? So cheek defects are quite good to be reconstructed by local or pedicle flaps. Eyelid, medial canthus defects, again local tissue is far better. Lip defects, again using an Abbey or an Eslander gives you mucosa, gives you functional muscle, and you're able to keep commissure competence. Nasal dorsal defects, you can use a forehead, not the standard forehead, a paramedian or a median forehead. Buccal mucosa defects again can be reconstructed with some local flaps like the buccal fat pad or the temporalis. Tongue defects of late are being reconstructed with the FAM flap, which is an axial flap perfused by the facial artery into the cheek mucosa. And pharyngeal defects again, there are 2 options for pharyngeal defects. Either you use faciocutaneous tissue or you use visceral tissue, but in most cases we can get away with the faciocutaneous tissue. So what are the reconstructive goals for each of the sites? So for tongue, it's the preserving the mobility as much as possible. If possible, give a mucosal cover. If it's a complex defect where the mylohyoid has been taken away, we should give orocervical separation. And in total glossectomy, the aim is to provide bulk so that the flap has palatal contact. For buccal mucosa, it's mucosal cover and skin requirement. Floor of mouth again is mucosal cover, maintaining the mobility of the tongue, orocervical separation. Lip is volume, using a sling and maintaining commissure competence. For pharynx, you have to reconstruct the conduit for the patient to be able to swallow. The palate is oronasal and orosinus separation, and mandible is to give bone continuity, form, and occlusion. Now, I'm sorry for the picture not looking that great. This is from Gillies and Millard's book of Principles of Plastic Surgery way back in 1957. I want you to read this line very carefully. Treat the primary defect first, borrow from Peter to pay Paul only when Peter can afford it. So always remember that when you recruit tissue, you should make sure that the tissue can survive, will survive, and you're not stretching the boundaries of the flap. Now, these are the four common flaps that we use as regional flaps. So, pectoralis, deltopectoral, supraclav, and latissimus dorsi. So, for pectoralis, the advantages are large skin paddle, it's robust, wide range of defects, ease of harvest, minimal donor site morbidity because the lats is still in function, and it's good for a salvage surgery. So that is why my principle is that if a patient can be reconstructed with a free flap, I would do that first, especially in advanced cases where you're expecting recurrences. By using the pec major up front, you burn your bridges. You don't have any other reliable flap in the salvage option. So, as far as possible for advanced tumors, for patients who you think will need another free flap or another flap down the road, preserve the pectoralis. The DP has a smaller skin paddle. Distal vascularity is a problem, which I mentioned. You might have to delay the flap. It's got good thin skin, so it's not as bulky as that of the pectoralis. The reach is limited. Sometimes there is need for skin grafting the donor site and may need flap delay and then flap division to insert the flap into the defect. One thing, I will tell you the nuances of DP when I show you the pictures of the DP. So supraclavicular is an intermediate skin paddle thickness. It's got good vascularity. The reach is intermediate. The donor site, if properly planned, can be harvested and closed primarily, and the skin can be thin in some patients. The lettuce has the largest skin paddle possible because you can basically raise the entire skin of the latissimus dorsi. It's a very robust flap, but patient repositioning is a problem. The reach, I've written intermediate, but you can go up to auricular defects or temporal bone defects, and the tunneling has to be careful, and it's slightly difficult when the pectoralis major is still intact. So if you look at the pectoralis major flap, it was described in the 70s by Aryan, and it revolutionized head and neck reconstruction. So before the pectoralis major, the defects were usually reconstructed in stages, and most of them were based on carrier flaps. And a lot of recruitment from the cervical skin, a lot of skin grafts. So this was the first time that a defect would be reconstructed in a single stage transfer. It's got robust vascularity from the thoracoacromial axis. The muscle is of good vascularity, even though the muscle has three different supplies. We can use the medial pedicle to vascularize the entire pectoralis major muscle and the skin. And even in the era of microvascular flaps, there are certain indications for this flap. So this was the first description by Aryan about the pectoralis major. Note in this picture, we have marked the paddle vertically downwards. Now, this is the earliest description, so there have been modifications after this. But whenever you raise the pectoralis major, you should never compromise the blood supply of you can harvest this entire territory of the pectoralis major and the overlying skin. But what is important is, once you cross its attachments to the rib inferiorly, everything else is the rectus sheath. There's a lot of people who say that the rectus sheath has vascularity, but that is not true. This part of the flap below the muscle is totally random. So when you plan this flap, you can either, the way you plan the flap is first you palpate the muscle capture by putting your fingers around the muscle in the anterior axillary fold. You do that first, and then you mark your paddle. The paddle is the narrowest at the sternum, so if you want a narrow paddle, thin paddle, you just take a parasternal skin island. If you want a long flap, you can make it sausage shaped or boat shaped. The nipple can or need not be included, and in women, an inframammary skin paddle is quite ideal. So the markings of the pectoralis major, I don't follow the conventional markings. All I do is inverse plan the reach and then mark the size of the pectoralis that is required, palpate the muscle to see how much muscle capture is there in the skin, and then make modifications to the size of the skin paddle that is harvested. So here you can see this is a patient who has peripheral vascular disease. He had a tumor of the mandible that was involving the skin, the alveolus, and the floor of mouth. And this is reconstructed with the pectoralis major. In this patient, we were lucky that the muscle wasn't too bulky, so aesthetically it is okay. But for the reason his neck vessels were very bad. All his neck vessels had atherosclerosis, so we couldn't use a free flap in this patient. And one of the ways that is important to plan is to inverse plan. That is the only way you can plan a flap. So what I do is I take a glove paper or whatever that you have in theater. I mark out the defect in the glove paper. Then I mark out the pedicle, which is possible from the mid clavicular point all the way to the pectoralis. Here you can see there's a line showing you the capture of the muscle on the skin paddle, and then we flip it to see if it reaches the defect. And this is how it looks like. Unfortunately, in him we needed a large skin paddle, so we had to skin graft the chest. The problem with taking a large skin paddle and skin grafting the chest, you should remember that it interferes with breathing somewhat. So chest expansion might be a problem. So try to avoid a large or a tight closure of the chest in patients who have COPD or have other respiratory problems. And the other important thing when you're raising the pectoralis major is that you should leave the perichondrium on the ribs intact, otherwise the skin grafts will fail. I have experienced pectoralis majors done outside which have come back with rib osteomyelitis, and we had to use the contralateral pec to close the ribs and then skin graft on top, or we had to use the latissimus to close the exposed after curating and the ribs. After debriding the ribs, we've had to put the LD or the contralateral pec major. So in patients who have breathing issues, try to keep a supple closure as supple closure as possible. Otherwise, you might have to recruit tissue from the opposite side, or from the superior epigastric axis, or from the latissimus dorsi. But this patient had a bipaddle defect, so you can see how much of pectoralis we can actually recruit in such patients. Now, the DP flap was described by Bakamjian. It's based on the perforators of the internal mammary artery. And usually the second and third perforators are what are used. There are 3 angiosomes supplied by 3 different vessels. So up to the deltopectoral groove, whatever we harvest will work, because that's the angiosome concept of Taylor. If you cut off the skin as a flap, the second angiosome will work, but the third angiosome, which is removed, will not work or can be doubtful in vascularity. So we raise the entire deltopectoral flap, keep it back on the patient so that the choke vessels open up and the distal perfusion improves, and we use the flap after a delay of 2 to 3 weeks into the defect. Now, the important thing to remember here is that the cephalic vein runs through the deltopectoral groove into the thorax, so be careful to not injure that vein, and the defect which occurs after transferring the flap can be closed by skin graft. So this is a patient who had cervical cutaneous defects. This one has a defect after a tumor excision. This one has a plate removal. So one of the important things of insetting a deltopectoral flap is that your defect should not be very small. you should make your defect larger. The reason is the distal skin has to capture blood supply from the defect, because later you will divide this deltopectoral flap and discard it or put it back. So your defect should not be too small. Otherwise, the capture of the blood supply from the surrounding tissues becomes difficult and might not be sufficient to supply the deltopectoral. So you have to make sure that the inset is nice and wide, and after 2 or 3 weeks, once the distal segment has taken its blood supply from the surrounding tissues, you can divide the pedicle. Now there are people who have tried to deepithelize and tunnel it and then use it for pharyngeal reconstructions, but it's better not to disturb this pedicle. And here you can see this patient had plate exposure, the plate was removed and a DP flap was placed for the patient. So this is the picture of how to raise a DP flap, and this is the picture of showing you the cephalic vein in the deltopectoral group. Now I mentioned standard forehead only because we have to know about it, but it has to be the last option that you have for the patient. So because the donor site is quite ugly and it is a permanent stigma on the patient's face. So this is the standard forehead flap. You mark it palpating the anterior branch of the superficial temporal artery. The posterior branch goes up here to the temporoparietal fascia and the temporalis muscle. Now, if you have a Doppler, it's ideal. Otherwise, you palpate for the pulsations of the superficial temporal artery. And this palpation should be done after occluding the contralateral superficial temporal artery. Otherwise, what happens is there is cross flow and this superficial temporal artery will appear pulsatile. So you have to palpate for the pulsation after occluding the opposite side superficial temporal artery. So this flap is raised above the periosteum. So the frontalis will be included in the flap. And try to be careful of not to damage the eyebrows. The flap is raised just in the supraperiosteal plane. And when you are closer to the temple areas, to the areas of the temple, the temporalis muscle will come into the picture. So when raising from the other side, leave the temporalis on the patient. You don't include the temporalis into the defect, into the flap. And then you raise it till about the lateral canthus here, but don't go beyond it because the muscle becomes very superficial here. So this can be used for an angle of mouth defect bipaddled. You have to tunnel it under the skin and over the zygoma if possible. If there is a maxillectomy and zygoma has been removed, then it's easier. So this can be used for oral defects, cheek defects, and for lip defects. And you close the donor site with a full thickness skin graft that is not fenestrated. That gives the better aesthetic results. And this is a patient who had a lip defect, a cheek defect, intraoral defect. So we used a large forehead flap. For him, all the other flaps have been used. So we just used a large forehead flap to reconstruct the commissure. Now, this wasn't his final picture because we did put a sling and hitch it to the malar prominence. So that gave him lip competence. And he had a couple of other local procedures done, and his lip looks aesthetic now. Now, this can be also used for through and through defects of the mandible and the oral cavity. And in this case, we had just used the flap as a carrier so that the skin will supply the blood supply to the forehead flap, and then it was divided and put back later. The other important local flap that many of you would use is the nasolabial flap. Now, the nasolabial flap can be both axial and random. Axial meaning there's a vessel running under it, and random meaning that there's only the dermal plexus that supplies the flap. Now, this can be superiorly based or inferiorly based. Superiorly based flaps run off the angular artery, inferiorly based flaps run off the facial artery. You can still do it after a neck dissection if the facial artery has been ligated, and this is because of the excellent dermal supply of the face. So usually any other flap, your length and breadth ratio is 1:1.5. But in the cases of the face, you can take in 1:5 ratio, length is to 5 breadth ratio. So this flap. Many people ask me what plane you raise it in. You raise it in the subcutaneous plane so that you don't damage the dermal vasculature or the facial artery if it is still intact. And this can be used for a variety of defects. In this patient, we used it for a lower lip reconstruction because his hand Allen's had failed. So we didn't have a radial forearm to suture this defect. Now, the only problem with this flap is the facial scar. It's good to do in patients who have black skin, especially older patients. But in a younger patient, this might leave a scar which can be quite distracting to the patient unless he has very prominent nasofacial folds on the other side of the face. Now, this is the supraclavicular flap that I had mentioned. So the supraclavicular flap, the perforator is in this triangle. It's from the transverse cervical artery. So this is the SCM, this is the clavicle, and this is the external jugular vein. You Doppler the perforator at the center of the flap, and this is an axial flap. So the distal part of the flap is over the deltoid because here the circumflex humeral will supply the rest of the flap. So up till here the flap is fine. You can raise a thicker flap if you want, a wider flap if you want for pharyngeal reconstruction. But this was a patient who had a cutaneous defect, and then we just rotated the flap into the defect, and this is the final closure. Now, the supraclavicular flap, the donor side closure sometimes can be tight, so you need skin grafting, and tunneling it into the oral cavity might be difficult, but it is still a very versatile flap, and it's a newer flap that has been described for head and neck reconstruction. Now, the other flap that people commonly use is the submental flap. Now, the submental flap has a few prerequisites. The first of all, most important of all, the patient should be node negative. Both clinically and radiologically, the patient should be node negative. Second, the patient should have lax submental skin. And third, it's preferable in older females than males because in males you have the problem of hair growth, which can be very troublesome from the patient. Though the blood supply is the submental artery, which is a branch of the facial artery running along the mandible with its vein, and it pierces the anterior belly of digastric and supplies the skin over that submental area. So the width of the flap that you can take is how much you can close primarily, and you can remove the submandibular gland and the 1A adipose tissue if you need, but you'll have to ligate the distal runoff of the facial artery to mobilize this flap, and never try to thin the pedicle because the vein has multiple connections and may get damaged. So in these cases, it's better to leave the pedicle thick, and it's quite good for patients who have tongue defects, who are node negative, who are not candidates for other flaps. So this is a submental for a tongue defect. Now, another new flap that has been described is the infrahyoid flap. So the infrahyoid flap is based on perforators traveling through the strap muscles from the superior thyroid artery. So it's a midline neck flap. You raise it along with the strap muscles above the thyroid gland, ligate the branches of superior thyroid to the thyroid gland, and then proceed with the dissection up. The major problem with this flap is the venous congestion, and that is because we don't take care to preserve the vein. So here in this case, you can see that the venous supply is from the external jugular vein. So that can be a variation. So that passes through this soft tissue and goes into the flap. And this is the superior thyroid artery. Through the perforators and the strap muscles supply the infrahyoid skin paddle. So it's good for floor of mouth. It's difficult sometimes to reach the tongue. You have to close the neck with a Z-plasty so there is no scar contracture. And if the flap becomes congested after the surgery, release a few stitches and make sure the tunnel is wide enough. Sometimes it picks up, sometimes it does not, but that is one of the disadvantages of this flap, and that is venous congestion. So for palatal defects, there are two options. I told you that if you have mobile mucosa, especially in the cheek or in the tongue or the floor of mouth, we should not use muscle because muscle will heal by secondary intention and cause contracture. But the palate is hard, keratinized, fixed mucosa, so you can use muscle to cover the palatal defects. This is a temporalis muscle flap which has been tunneled. The way you raise this flap is you raise it off the calvarium, right? You preserve the deep temporal supply to the flap and the superficial temporal supply to the flap. Then you detach the temporalis fascia from the zygoma and tunnel deep to the zygoma and bring it out into the oral cavity. Now this will heal and keratinize, and because it's non-mobile mucosa, we don't mind that scar tissue over the palate. So this is one of the good uses for a temporalis flap, but never use it for mobile mucosa. Now the special area here is the pharyngeal reconstruction. Now all of you know if we do a total or a partial pharyngectomy, we have to reconstruct the defect. Now there are various options. One of the options is using fasciocutaneous flaps and the other option is using visceral flaps. Now if the stump of the pharynx is available in the neck, if the stump of the esophagus is available in the neck, then we use fasciocutaneous flaps. That is possible. So the two fasciocutaneous flaps that we use are supraclavicular and the pectoralis major. But if the esophageal stump is not available in the neck, then a gastric pull-up is the only option. Now, there are some advantages and disadvantages between using a skin and a visceral flap. Now, the problem with skin flaps is anastomotic stricture is a very common problem in skin flaps that are being used for pharyngeal reconstruction. And sometimes if the flap is very bulky, it becomes difficult to close the neck. Now, how to avoid anastomotic stricture is to do something called the lock and key mechanism, where you slit the esophagus for about 1 centimeter and make a V there, and then make a V in your fasciocutaneous flap at the edge and feed this V. So in essence, what we are doing is we are breaking the circumference of the esophagus so that you are planting skin inside at different points of the esophagus. This will avoid cicatrization and will avoid anastomotic stricture at the lower end. Now the upper end is a different matter altogether. When you plan the flap, that is when you plan the pectoralis major or supraclavicular, you should make the part of the flap that goes to the base of tongue much wider, because the base of tongue is much wider than the esophagus. If you have a uniform tubed flap that is having the same circumference and diameter at both ends, you will end up making the upper end very narrow and very constricted. So whichever part of the flap goes to the tongue and base of tongue, that should be made wide. So supraclavicular, the advantage is it's relatively hairless and thin. It's good for pharyngeal reconstruction, but always remember the distal part of the flap goes to the base of tongue, and that is a very critical point there. So the vascularity of the distal part has to be kept in mind. Only then the flap should be taken. By scratching the flap or by using ICG, you can look at the distal part of the flap here. And like I said, it has to be a very wide funnel in the distal part and the proximal part, and the distal part can be as per the size of the esophagus. Now, in total pharyngeal reconstructions, the breadth of the flap that you take, either pectoralis or the supraclavicular, should be at a minimum of 8 centimeters. And it should be more if the patient is obese, because it's difficult to tube an obese flap. So 8 centimeters is what you use for total pharyngeal reconstruction. And if you do a partial pharyngeal reconstruction, in my book, it is better to have at least 4 centimeters of residual mucosa on the prevertebral fascia. I would prefer 6, but 4 is available, then I would do a patch pharyngoplasty. So this is a supraclavicular flap that is being tubed and taken into the neck of the patient. And this is the pectoralis which is being tubed for the tubed pharyngeal reconstruction. Now the problem with pectoralis, as I mentioned, is In bulky individuals, it's difficult to close the neck. So in those cases, we just do skin grafting to close the neck. But this is a very robust flap. It works well. It also has good muscle cover, promotes healing. The only downside is that patient will have a skin graft, and the skin graft might react poorly during radiotherapy. So the comparison between PMMC and supraclavicular, PMMC is large skin island, robust muscle adds to vascularity. There's a lot of data in the salvage setting where it reduces fistula rates, but tubing might be difficult. And in high defects, there could be pull of the flap with possible sutured dehiscence. Supraclavicular is easier to tube, but lacks muscle to take on vascularity and no data on preventing fistulas. Now, those were some of the common scenarios that you'll face when it comes to using local or pedicle flaps. But then free flaps are the norm now, and they offer wider options, bony reconstruction, larger flaps, not restricted by the pedicle. Multiple components can be replaced. You have full 360 degree of movement, and simultaneous harvest is possible. Of course, it requires more skill to harvest a free flap, involves microvascular anastomosis, and there is chance for failure. So these are the options: fasciocutaneous with muscle, and osteocutaneous. In fasciocutaneous, you have the radial forearm, anterolateral thigh, medial sural artery perforator, lateral arm flap, thoracodorsal artery perforator, and groin flap. I wouldn't say groin, I would say it's a skip flap, because groin is essentially a axial flap for as a pedicle flap. So fasciocutaneous with muscle, you have ALT, latissimus, and rectus abdominis, and osteocutaneous, you have fibula, DCIA, and scapula. So these are some of the flaps. The first picture is the radial forearm. The second picture is ALT flap. This is a thoracodorsal artery perforator flap, and this is a muscle-only vastus lateralis flap. Now, when you look at the options for bone flap, you have the fibular flap here, which has been osteotomized to fit a defect. You have the scapular flap here with the lateral border of scapula and the skin paddle. And then you have the DCIA, that is a deep circumflex iliac artery flap, along with the internal oblique muscle. Now, the fibula is the best because fibula has dual blood supply. So you have the periosteal blood supply, and then you have the endosteal blood supply also. And then through the septum from the peroneal artery, piercing the deep fascia, the skin also is perfused. So unlike other flaps, this has dual blood supply. So for soft tissue, radial forearm has been the workhorse flap for decades. It is perfused by the radial artery and its venae comitans. Virtually the entire skin of the forearm can be harvested. It's thin, pliable tissue, and it's ideal for lateralized tongue defects, buccal mucosa, and palate. So this is the harvest of a radial forearm. You can see this is the radial artery and its VC, and this is the cephalic vein. Now the cephalic vein will drain this flap, but if it's at the extremes of the skin paddle, then it's better to avoid the cephalic vein. People prefer the cephalic vein because it's larger and it's easier to do the anastomosis. But let me tell you a trick here. If you follow the radial artery, the VC of the radial artery as proximal into the cubital fossa, the superficial and the deep systems will join together. So this VC will join this cephalic. So you can get 3 veins in one vein, and you can do a large vein anastomosis. All you have to do is to follow the VC as high as possible, and the superficial and the deep systems will join together as one vein. And always remember that you have to do Allen's test to see for the ulnar collaterals. If it fails, then we cannot use this flap. So this is the flap for a lateral tongue defect. The next flap, which I like a lot, is the lateral arm flap. So it is based on the PCNA, which is coming from the brachial artery, and it's skin from the lateral arm. It's a septocutaneous perforator. meaning that the perforator is run through the septum, same like the radial forearm. So there's no perforator dissection here. So it's a relatively safe flap to do. So as I mentioned, it's from the PC RA and the PCNA, and it is from the skin overlying the triceps and the brachialis and brachioradialis. The pedicle is a bit short. This is the flap. The pedicle is a bit short, and it is in close proximity to the radial nerve. So you've got to be very careful. This is the pedicle. The pedicle is slightly small and thin, so you have to have good microvascular expertise to do this flap. The advantage is in a radial forearm flap, the defect is covered by a skin graft. The donor site is covered by a skin graft, and this can lead to graft exposure and debridement of the graft, especially if the patient is diabetic or has vascular disease. You have to skin graft it. Whereas in the lateral arm, it's primary closure of the defect. So it's one of the good flaps to do, and it really helps in patients who need bulk also. Now, this is a medial sural artery perforator flap, the branch coming off the popliteal artery. So this is a tongue with a compartment excision. This is the flap. Again, this defect can be closed primarily. Now, the difference between radial forearm and MSAP is that in radial forearm, you're sacrificing a big named vessel in the hand. So if the patient develops ulnar disease later, there could be a problem. Whereas here, there is no major artery that is sacrificed. This is how the tunneling is done in our department. Red rubber catheter, flap is fed, the pedicle is fed into the red rubber catheter, sutured there and pulled out into the neck. And this is how the flap looks on the tongue of a patient. It's relatively hairless also. ALT is another versatile and common flap that all of us use. So the blood supply for the ALT is, you have the lateral circumflex femoral artery, and that has three branches. So the descending branch of the lateral circumflex femoral artery supplies the skin over the vastus muscle. This can be either a septocutaneous or a musculocutaneous flap. You can harvest virtually the entire thigh based on a single perforator. You can raise the muscle also as a chimeric flap, and it is very good for large volume, large size defects. So it's large skin paddle, concealed donor site, can be harvested with skin or skin with muscle. Facial arter can be used to anchor the flap to provide structural support to the floor of mouth. Minimal donor site mobility, two-team approach, and good caliber of vessels. And you can also thin, here you can see this flap has been thinned to this size. So it is also possible if you leave 1 centimeter circumference, diameter around the perforator, the rest of the flap can be thinned out quite drastically. And for massive glossectomies, you can contour the flap. So here we need the tongue, we need the tonsil, and we need the floor of mouth. And you can actually contour the flap to where you want it to fit. So this is how the flap goes in, and this is how the patient looks like after the flap has been inset. So for total glossectomy, you should have good palatal contact of the flap. You should eliminate insensate gutters. The flap should be protuberant, and the flap should be aesthetically acceptable. So for isolated base of tongue defects, you need volume replacement, which again can be done by the ALT flap. So this is a transmandibular approach, a base of tongue salivary tumor resected, and an ALT flap providing bulk to the base of tongue. So if you have a patient who's got a marginal mandibulectomy and a buccal defect, you need a thin pliable flap. So that is where the radial forearm really shines. So this is a patient who had a marginal defect, upper alveolectomy, and part of the masseter being excised with reconstruction by a radial forearm. You can see that the pedicle is really long, and it can reach virtually any part of the neck. Now, if you have large cheek defects, which have a lot of dead space, so this patient had a posterior segmental mandibulectomy, upper maxillectomy, and ITF clearance, it is always better to use a bulky flap with some muscle. So this is an ALT flap in the patient, and you can use the muscle to obliterate the ITF. This is another patient who had an orbital exentration. So she needed multiple areas to be reconstructed. So 2 skin paddles, which have been divided based on the dermal supply. A bit of the vastus attached to the skin paddle, then vastus separately. The reason was we wanted to give her an orbital prosthesis later, so we can debulk all of this. So part of it went for the palate, part of it went for the orbital cavity, part of it went for the skin, and this part, which is skin grafted, she will receive an orbital prosthesis. Another flap that we have started doing regularly is the transverse upper gracilis. All the surgical oncologists would know that this is a good flap for breast reconstruction, but I prefer it for total glossectomy defects because you can plan the flap. This is the gracilis muscle with its blood supply and obturate and nerve. The skin paddle is transversely placed, so this is a drawing of the mandible. So the muscle goes to the mandible everywhere, and the skin remains as a protuberant skin with good palatal contact. All of this will mucosalize because the floor does not have, at least towards the gingiva, the floor is keratinized. So this part of the flap on the 2 sides would go to the floor of mouth, and the protuberant part will be the tongue. Now, quickly, bony reconstruction. Fibula is the best amongst all the flaps that we have. So good bone length, good bone quality, good bone shape. You can harvest a lot of skin. Tissue match is good. Osseointegration, if you decide to put implants, it's very good. You have a lot of pedicle length, and the pedicle diameter also is excellent. But in patients who are having hypertension, who have peripheral vascular disease, atherosclerosis, it's always better to do a Doppler to see for the triphasic vein flow or triphasic arterial flow, in the peroneal vessels, and no narrowing of the anterior tibia or the posterior tibia. And if the patient has any skin changes or nail changes, better to avoid this flap. The only problem with the fibula is that the donor site again has to be closed with skin graft, which can possibly lead to exposure of the peroneal tendons. So this is an example of how you can osteotomize fibula. The advantage of fibula is you can take out wedges of bone between the different segments. That's called an osteotomy to contour the flap, because the flap has blood supply from both the periosteum and the endosteum. So in this case, as you can see, if the periosteum is maintained, even the proximal part of the flap will still be perfused. So these are some of the pictures of our patients who had fibular flaps. You can see that after the wedge osteotomies, the flap heals very nicely, and good bone unity, union along the bone segments and with the native mandible. We always use reconstruction plates in Amrita because they are load-bearing plates. The load-bearing plates are the ones which will help in healing faster. I know people say that there's a high chance of plate exposure, but it all depends on tissue handling and how you radiate the patient afterwards. The other important thing is many plates tend to deform. They tend to torque, they tend to deform, and they tend to fracture over a period of time. So as per the AO principles, Amrita, we always use recon plates for mandible, especially the low profile, the newer low profile ones. For maxilla, yes, we use non-recon plates, but most of the plates are specific models now for our patient. So this is dental implants placed in the mandible after a fibular reconstruction. And this is the same patient after the previous picture was the one before she had a tumor ablation, and the next picture is one which she had after tumor ablation. So you have to ascertain your priorities upfront if you're planning for a maxillar reconstruction, whether you need alveolus, whether you need nasal buttress, whether you need orbital floor, or you need zygomatic buttress. So you have to ascertain your reconstructive priorities upfront. So the fibula is very good for maxilla because I told you you can osteotomize it in different ways. So you can plan one for the orbit, one for the alveolus. You can plan 2 skin paddles, and one for the orbit, one for the maxilla, and one for the palate. You can do a total alveolar resection of the maxilla. Then you can do for the alveolus, you can do the soft tissue for the nasal area and another bone segment for the orbit, or you can just do a standard osteotomy. or use a single bone segment for whichever maxilla you want to reconstruct, and a lot of FHL muscle to close off any maxillary or retromaxillary dead space. So these are some of the patients that we have done. We always do VSP in Amrita, virtual surgical planning in Amrita. So we get the skull models and the fibula models printed. And this patient needed an orbital mesh for orbital floor reconstruction. And this is the patient after the procedure has been done. You can see that the fibula has united quite well here. And this is the part that goes for the orbital ridge. And this is him after dental implants. So the DCIA is a very good flap. The importance of DCIA is that the pedicle is not affected by atherosclerosis or narrowing as much as the fibula. But the only problem is you have to sacrifice the internal oblique muscle. So you have to put a mesh there because the internal oblique is part of the flap, and the pedicle is short and the pedicle diameter also is very small. So you can use it for maxilla in the two descriptions as given by Brown. So you can use it as the alveolus side and the internal oblique comes for the palate, or you can use it vertically to reconstruct the anterior wall of the maxilla and the internal oblique comes to the palate. So these are some of the pictures of DCIA for the maxilla. And this is another picture for mandible. The advantage of the mandible reconstruction is that you can see you can take a very large piece of DCIA. By that I mean the vertical height of the DCIA. So fibula, the vertical height is not that great, so it might stop somewhere here. But if you take a DCIA, you can go up to the occlusal surface and give good vertical height, which is useful for dental implants. In fibula, the fibula is very small and it's only up to here. It's quite difficult to put in implants unless you double barrel the fibula. So another flap is a scapula angle flap. This was popularized by one of my mentors during my fellowship, Professor Clark. You can use the angle of the scapula based on the angular artery, either as a vertical orientation or as a horizontal orientation. This is a scapular flap. It's got long pedicle length, and you can use the teres major muscle for the soft tissue reconstruction. So for bony defects, if it's maxilla, if it's orbitomaxillary, these are the options. If it's alveolar, these are the options. In mandible, if it is a single axis defect, these are the options. And if it's multiple axial defects, these are the options. So in conclusion, what you have to remember is body habitus, nature of the defect, and surgeon comfort should decide the flap to be used. Majority of the defects can be reconstructed with radial forearm, ALT, and fibula. Pay particular attention to the donor site morbidity. Flap monitoring and re-exploration skills are mandatory for successful microvascular practice. So thank you for your time. I have a YouTube channel called Learn Head Neck Surgery, all in one word, Learn Head Neck Surgery. It has all the flap harvests of all the flaps that I have described and some more flaps also. So you can go through them to learn about the flap harvest. And if you have any doubts, please let me know. Thank you very much. I think I kept to my time also. Thank you very much.
Deepak, excellent lecture. There are few questions. Dr. Biplab has questioned how to choose between MSEP and FREF for buccal mucosa defect. When to do each one?
Yeah, so you have to see the thickness. First is the thickness of the flap. If you need thin, pliable skin, if there is not much third dimensional loss in the cheek, then you can go in for a radial forearm. So multiple reasons. So that is one of the reasons. Second is to see how hairy the patient's hand is. If the patient's hand is very hairy, then you go ahead with the MSAP rather than the radial forearm. Then we ask the patient what his choice of aesthetics, what does he want. That decides also whether you want to do an MSAP. Technically, both flaps are very simple to do. It's not the technique which decides which flap should be done. It's the third dimension defect. If the third dimension is too much, the MSAP is better. If the patient doesn't want a skin scar, the MSAP is better. If the radial forearm is very hairy, MSAP is better. But if it's thin, pliable skin that you need and you're not comfortable with small vessel anastomosis, radial forearm is better.
Also, Biplab, if you need a very long pedicle, radial forearm has that advantage. If your anastomosis is in the opposite neck because the ipsilateral neck is compromised, then for the vessels, then you may not be able to do MSEP because it doesn't have a great pedicle length like radial forearm. Hello, Deepak, are you able to hear?
Yeah, I'm here. Which flap is better for mandibular reconstruction in laborers? Fibula versus PM. That's not even a question. You've decided for bone reconstruction, correct? If you have decided for bone reconstruction, then you look at whether the patient's a laborer or an astronaut, it doesn't matter. If he wants bone reconstruction, you do bone reconstruction. I don't think, I have seen people who have had fibulas, who run, jog, who participate in marathons. So that is not a real problem. They might have some weakness, but that is not a real problem. Doing a scapula for a laborer is bad because for 3 months at least they have problems with the shoulder movement. DCIA is okay, but if they're lifting heavy weights or if they're into heavy manual labor, then there's chances of hernia with the DCIA. So I would say that the fibula is still a safe option, but I wouldn't be comparing fibula with PMMC. I don't think that is a right comparison to make.
So there is no way you can reconstruct the bone with PMMC. I mean, as he rightly said, the rib and the sternum with PMMC can be used, but that is just to mention. The results are really disastrous, and these patients needs many a times when you need to remove the bone, these patients will need post-operative radiation as an adjuvant treatment. So these bones which are included with pectoralis major may not withstand that, and then you have a lot of osteoradionecrosis, fistulas, you need to do debridement. Many a times patient may not be able to complete the radiation. So if you need to replace the bone, you have to replace it with free microvascular flap. It can be fibula, scapula, DCIS as Dr. Deepak said, according to the availability and indication. What is more important is what Dr. Deepak said, that to feed the Paul, you can rob the Peter, but you should know that whether the Peter can afford it, which is extremely important. Say like MSEP and radial forearm, if your LN is negative, you can't take a radial forearm. If the ulnar vessels are compromised by previous injury, I don't think you can take that radial forearm. So you have to see what is the need at the defect side as well as what is possible at the donor side.
Yes, sir. The next question is what things to be considered to maintain commissure completed. So the most important thing to consider is how much of remnant lip that you have, and can you do orbicularis to orbicularis suturing, that is from the lower lip orbicularis to the upper lip orbicularis suturing. If your commissure is replaced with soft tissue flap, then you have to do a sling. You can take a palmaris or facial lata or whatever you want, and you should do a circumoral sling. But remember, don't try to overdo this primary suturing or this sling, because the minimal intercommissural space to allow for a spoon to be used by the patient is minimum of 2 centimeters. So anything less than that, even a spoon won't go through his mouth. So be liberal. There are different schools of thought. Some people say microstoma is better to correct later. Some people say macrostoma is better later. But I think macrostoma is better because feeding is very important during radiation. and you don't know how much the radiation is going to affect the mouth opening. So I would prefer some amount of macrostoma and then leave it like that. The next question was when to use obturator for maxillary defect. Again, when the patient is too old or morbid to accept free flap. Second, if the patient has good mouth opening. Third is not much of soft palate extension. Four is they have strong teeth which are non-caries and which have intact roots, and there is no bone resorption to use the obturator. These are some of the indications for using obturator.
And for obturator, you have to understand that even if there is an ideal case for obturator, you must explain that there is an option of free microvascular bony reconstruction, because the option of bony reconstruction can give a much better post-operatively the outcome, because obturator has its own problems of maintenance. Obturator has its own problems of repeated issues, while once the bony reconstruction is there with good implants, it gives an excellent quality of life outcome. So all in all, at the end of the day, if there are both the options, it's patient's choice. You have to make them understand the pros and cons of both.
Yes, sir. There's a paper by Moreno where they have looked at comparison. It's in head and neck. They've compared the outcomes of obturator versus free flap. So any palatal defect more than 50%, free flaps are better in outcomes of speech and swallowing. Are you conducting a cadaver program in Amrita? We just finished ours. Next year we will. Just let us know, send us your email. We will keep you posted on next year's course. What are the indications for primary ALT? If you have multiple defects, multiple subunit defects, you need multiple skin paddles, you need third space obliteration, then you use a chimeric ALT flap. Indications for FAM flap. Defect. So it's just putting unnecessary tissue there. So as long as it's 1/3 to half defect, and remember the FAM's donor site is not very great. You have to recruit a lot of cheek mucosa, and you have to close that cheek mucosa primarily. So I'm not a big fan of FAM because of the donor site, but a lot of people in our unit still do it.
I think that finishes off the queries and questions from the trainees, and I think we can close this today. Thank you, Deepak. It was a very exhaustive and comprehensive lecture for head and neck reconstruction, and this will be posted on the NBE website also, so that those who could not attend can take advantage of it, and those who have already attended can go back to it and learn again from it. Thank you so much, Deepak.
Thank you, sir. Thank you so much.
Thank you so much, everyone, for joining in this webinar session. Thank you to all faculty members. Have a good day.